क्वेश्चंस कौन देखेगा? हम ही को देखने? अनिकेत कैसे देखेगा? फिर अनिकेत यहीं से प्रेजेंट करेगा। तो ऐसे ही कर लो, माइक लेके यहीं आ जाओ, वहाँ मत खड़े हो, माइक लेकर आ जाओ अपना। So इसको ये आपके पास रह जाएगा ना? आपके पास रह जाएगा? इसके पास नहीं, ये आपके पास रह जाएगा। ये नहीं रहेगा। हाँ नहीं, वो तो ठीक है ना सर, गीता को भेज देते तो वहाँ पे एक कमरे में बिठा देते हैं अभी, ठीक है? फिर वहाँ पे ऑफिस में बिठा दो, तो कट पता नहीं। जाओ जाओ, घुमा लो। तुम लोग आगे आ जाओ, सीटिंग वेरी खाली रहा। कनिका जी इधर आ जाओ, मनीषा तुम आ जाओ। ये तो बिकॉज कृष्णा का नाम लेके मैम अनिकेत कैसे करेगा मैम? वो आंसर्स को टाइप करना पड़ेगा ना फिर। आंसर्स वी विल बिल्कुल वर्बली एंड वी हैव टू से इट। चेक 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 आपका आ गया चेक। हमें कौन से माइक वो देखना है कैमरा में? दिस कैमरा और दिस कैमरा? उसको देखना है, सामने देखना है। लगाओ ना, कनेक्टर दे दो यार, कनेक्टर दे दो। मिल गया तुम्हारा? ऐसे बिठा दो, ऐसे उल्टा सो दैट दे कैन सी हिम, ये बच्चा दिख नहीं रहा है ना। ओके, तब एक कुर्सी को ऐसे घुमा करके यहाँ बैठो ना, कुर्सी को इधर ऐसे घुमा, हम ऐसे ताकि बिठा दो। बस एक कुर्सी है, ये आ गई, ये इसके लिए खोल दो, बांध मत। ये आप साथ में ही बैठ जाओ, दो कुर्सियाँ कर दो। वैसे ही इज एक्टिंग होस्ट। आप साथ में बैठ जाओ, कुर्सी ले लो, एक और कुर्सी ले लो। अभी वो यार तार उनकी चल नहीं रही थी, तार करने के लिए उन्होंने चेक करने के लिए दूसरी तार लगाई थी, तो इसलिए वीडियो ब्लैक हुई। वो आ रहा है, कनेक्टर चेंज करो ना यार, कनेक्टर वो रखने वाला बंच वाला कनेक्टर लगाओ। चेक चेक everything so lost, इधर उधर देख रहा है, फिर जा रहा है। पूछना है ना, मेरे नाम भी वाइज कर दिया ये बीच में। नहीं, कुशाग्र राइट, कुशाग्र राइट, हंस। कुशाग हंस, व्हाट इज निमिषा? निमिषा, उसे कनिका है, उसे श्वेता, शिल्पा, शिल्पा, अंबी, कनिका, इसके बराबर मयूरी मैम। हाँ, मैं तो मयूरी है। हाँ, फिर आपका नाम हो गया? Why are we not starting? ये स्टार्ट क्यों नहीं कर रहे? अपनी पीजी इज मिसिंग है। ये कनिका, उधर निमिषा, जूही का, हाँ जूही के साथ में किरण, केशव का, ये केशव और किरण ना दोनों गेट ए लिटिल कंफ्यूज इन माय माइंड एट लीस्ट। निधि, अनीता, प्रभजोत, श्वेता is gone. That's Shweta? No. Shweta is ना? Shweta and Chaitra, front. सृष्टि तुम्हारे पास है ना माइक? हाँ। वैसे सृष्टि बोलती है तो किसी और को बोलने तो देती नहीं है। एक काम ये भी कर सकते हैं, आई कैन पुट इट टू मी, ये मैं रन कर लूँगी, तुम वो देख लेना। हाँ नहीं मतलब अगर ओके सॉरी, हाँ मतलब इन केस इट विल बी फॉर द ग्रुप, तो यू कैन रीड द क्वेश्चंस आएंगे तो। रिफ्रेश कैसे होगा? And what is the name of this girl? Both of you can come in the front. There's enough seats here. Why do you want to keep them vacant? केशव आगे आ जाओ बेटा। वो कहाँ है बाकी हमारे यूनिट के? स्नेहा, गोपीनाथ। Now it's a respectable group at least. यहाँ इधर बैलेंस कर दो। Sit here. सूर्या, proper attendance दी है।
Check test.
Good evening and welcome to PG case discussion from Kalawati Children's Hospital, New Delhi. I welcome all the students and the students who are listening to this presentation from other centers in India. Today we have a case presented by a final year postgraduate student, Dr. Aniket Malhotra, and we are 3 faculty members here. I am Dr. Anju Seth.
I am Dr. Sharmila Mukherjee. Hello.
I am Dr. Preeti Singh. Hi.
So all of you, welcome, and if you have any questions in between, please type us, we are there. And Aniket, I'll ask you to start the case.
Good evening, I am Dr. Aniket Malhotra. I will be presenting the history and the examination of the case. I am presenting the case of Prince, a 5-year-old male Hindu patient, resident of Sector 18, Gurgaon, Haryana. The informant are his parents. He presented to us with complaints with parental concerns of short height, noticed since 1 year of age, and the child looking unusual and different compared to other children noticed since 1 year of age. At 1 year of age, parents noticed that their child was shorter as compared to other children of his age, and this was further confirmed when in the following years the child continued to lag behind in height as compared to other children. Parents also noticed that their child looked unusual and different compared to other children. They felt that he had protuberant eyes and nose, and that as the child grew older, they also noticed that his head size was smaller as compared to other children. But the patient had no apparent visual abnormality. Patient has difficulty in walking and his activity is limited. And parents also give a history of delayed acquisition of developmental milestones. And at present, the child can walk independently but cannot run. He can scribble. He plays with his siblings.
Aniket, I'll ask you to give the delayed developmental history in detail later. Because I think any child who has, if you think has a delayed development, you should be giving a detailed developmental history. I hope you're going to give us that, right?
I am.
So you can just say you're going to give us details later.
I will give the details of the developmental history later. There is no history of apparent hearing impairment. There is no history of hyperactivity, increased aggression, or sleep abnormalities. There is no history of any asymmetry of movements of upper limbs or lower limbs. There is no history of joint stiffness. There is no history of easy fatigability, breathlessness on exertion, sensation or increased awareness of heartbeat, swelling of face or feet. But the activity of the child is limited according to the parents. There is history of recurrent upper respiratory tract infections and chronic nasal discharge. There is history of excessive snoring during sleep, but no history of disturbance in sleep. There is no history of recurrent lower respiratory tract infections requiring admission or ear discharge. There is no history of recurrent diarrhea, foul-smelling, bulky or greasy stools, abdominal distension, pain abdomen, or poor weight gain. There is no history of dryness of skin, constipation, apathy, hoarseness of voice, decreased activity, intolerance to cold or neck swelling. There is no history of any bony involvement or prolonged fever. Despite his poor gain in height and unusual looks, he is a happy child according to his parents. His activity is good. He plays with his siblings and other peers and has good appetite according to the mother. There is no past history of any hospital admissions. In antenatal history...
Just wait. Is that all in history of present illness?
Yes, ma'am.
Do any of the students want to ask anything in history of present illness? We have a mic here. Any one of you? I will in that case ask Aniket to very briefly, not really go through the entire history again, but tell us what are the broad groups, all the histories that you have taken, what are you trying to look at?
Ma'am, I have tried to rule out the common causes of short stature.
Okay.
I asked about easy fatigability, breathlessness, and history of palpitations, swelling of feet to rule out cardiac pathologies.
Okay.
I asked for history of recurrent lower respiratory tract infections and ear discharge, and recurrent diarrhea, foul-smelling, bulky, greasy stools, abdominal distension, pain abdomen, for history of malabsorption, history of dryness of skin, constipation, and other features of hypothyroidism to rule out hypothyroidism, especially because the parents are also giving history of abnormal facies of the patient. And I asked about any history of bony involvement to rule out joint pathologies as a cause of short stature.
So in other words, you're trying to rule out systemic diseases leading to short stature, and among the endocrine diseases you looked at hypothyroidism.
Yes, ma'am.
Okay. What else? You asked a lot of other histories. You were saying something about limited activity and about sleep related issues and hearing. What were joint stiffness? What were those for?
Ma'am, the patient gives history of excessive snoring, but there is no history of disturbed sleep. It could be present in hypothyroidism. It could be present in other disorders like storage disorders, which could lead to obstructive sleep apnea. And
can I ask the student what is the commonest situation in which obstructive sleep apnea happens? Okay, adenoid hypertrophy. Very good. What else? Obesity. Obesity is another, especially morbid obesities. Obstructive sleep apnea is important, and of course adenoid hypertrophy. Okay.
Should I proceed?
Carry on.
In antenatal history, the child is first in birth order. He is a product of non-consanguineous marriage. Mother was unbooked and unimmunized during pregnancy. She did not receive any nutritional supplements. Fetal movements were perceived at 3 to 4 months of gestation and were normal according to mother as compared to other siblings of the mother of the patient. There is no history of any known medical illness in mother. There is no history of antenatal exposure to smoking, alcohol, radiation, or drug intake.
What is the importance of this antenatal history, Aniket?
Ma'am, antenatal exposure to toxins like alcohol or smoking can lead to short stature with dysmorphism, especially in fetal alcoholic syndrome. They have characteristic facial features, mid-facial hypoplasia, thin philtrum and thin lips. The upper margin of the lip is thin, and they have developmental delay and short stature as well. In birth history, there is the child was a singleton delivery, born at full term through normal vaginal route.
Aniket, 1 minute.
Ma'am.
You didn't mention anything about the quickening and the fetal movements. Isn't that important? Or did I miss that?
I did, ma'am.
Okay.
At 3 to 4 months
Why
of age.
is that important?
Ma'am, many causes of congenital infections or any exposure to teratogens can lead to delayed or early pregnancy insults. Hypoxic insults could lead to decreased fetal movements.
I think I'm looking for a better answer. Yes, Nimisha?
You'll have to take a
Press karna. It's in the front.
Ma'am, the various myopathies or the neuromuscular disorders, in that case also the child will present with a delayed development, and antenatally they will have the history of delayed quickening because the fetal movements will be decreased. In addition, they will have the poor swallowing, so they can have present with polyhydramnios also. So
okay. Anybody else? Anything else? Can you speak one by one, please? Hypotonia.
Any disorder causing hypotonia.
Okay. Any disorder causing hypotonia.
Will lead to decreased fetal.
All right, Namrata. Yes. You were saying something else? Major congenital anomalies. So basically, any genetic, structural, or metabolic disorder will affect the developing fetus in utero, and that will translate into a delayed quickening, may translate into a delayed quickening and decreased fetal movements. Right. Continue, please.
The child was a singleton delivery, born at full term through normal vaginal route at home. He cried immediately after birth. The birth weight was not recorded, but it was low according to the parents. In family history, the child is a product of non-consanguineous marriage. First in birth order, he has 2 younger siblings, a 3-year-old female sibling and a 2-year younger brother. There is a history of a spontaneous abortion at 3 months of gestation before this child. On studying the three generation pedigree chart, there is no history, no similar history in the family of similar facial features or short stature, mental retardation or developmental delay on either mother's or the father's side. In immunization history, the patient is
what does it mean? You have done a 3 generation pedigree chart and you have not found a child with these kind of looks. So what does that indicate to you?
Ma'am, the pattern of inheritance can give a clue to the diagnosis. The various.
No, but you have not found any child with similar features. So what does it mean to you?
Ma'am, it could be a de novo mutation.
It could be a de novo mutation. Anything else?
Autosomal recessive bhi ho sakta hai, ma'am, which
has not manifested in the previous 3 generation. Anything else? Why do we presume it's a genetic disorder? Could it not be any other acquired disorder? From what I have heard till now, one really can't differentiate so clearly that this is definitely a genetic disorder. Why could it not be an acquired disorder? Yeah, we will ask the camera to focus on this child's look, and we'll, I think, just look at some diagnoses are pretty much spot diagnosis. So looking at this child, I would not immediately say that this is definitely a genetic disorder. Can you please focus on this child's look? Camera, इसके चेहरे पर जरा एक बार फोकस कीजिए ताकि स्टूडेंट्स जो हमारे यहाँ देख पाएं. जस्ट ए लुक. हाँ, बस इसका आप थोड़ा इधर आ जाओ 2 मिनट के लिए, बस देखना है. टोपी उठा खोल देंगे. हाँ बस कुर्सी पे खड़े करा दो. नहीं बाद में एग्जामिनेशन के खड़ा कर देंगे. जस्ट फेस आई वांटेड. In fact, one of the things that postgraduates tend to do is jump at diagnosis, and if somebody has put a label, then everybody else refuses to think about it. That's a very common thing. So I would plead that please don't do that. Go with an open mind. The child has very suggestive, very kind of prominent features. So you might like to note them and let your mind get working. There are so many things that one notices here, which will, I think, come to in examination. But for the time being, just have a look at this child. Don't assume that a normal pedigree could also mean that it's a child who has an acquired disorder. Carry on.
In the developmental history, in gross motor milestones, the neck holding was achieved at 1 to 1.5 years of age. Turning in bed was achieved at 6 to 8 months of age, but the parents do not remember exactly when he started to turn from prone to supine or supine to prone. He started.
Aniket, I believe the term you should use is rolling over. Turning would not be an appropriate term.
The child started sitting with support at 1.5 years of age, sitting without support at 1.5 to 2 years of age. He started standing with support at 2 years of age, walking with support 2 years of age, standing without support 2 years of age, walking without support at 3 years of age. Presently, he walks stiffly with difficulty, cannot run.
So what is your interpretation of the gross motor milestones?
The crude gross motor age is around 11 months to 12 months since he can walk, but he cannot run.
So that's the current status. And what about the acquisition of the milestones from the
Acquisition
onset?
is also delayed, ma'am.
So the onset of acquisition is, the acquisition is delayed, and the current motor functioning is, the crude motor functioning is, he's
Equivalent
functioning
to
at the
a
age
child of 11 months, 11 to 12 months.
11 months. Why 11 months?
Ma'am, because
What
he
was
has,
the last thing which he can do?
ma'am, he can walk independently.
So if he can walk independently,
11-month-old. How many 11-month-olds can walk independently, Aniket? Very few. Hardly any. Very, very few. Walking independently. And have you asked further questions? What
I
else
asked
can he do
about
apart from
running, I asked
So
about
you-
climbing stairs
Yeah.
and jumping.
So
he does not do any of these.
So
Has he
that
been
means-
given an opportunity to climb stairs?
Ma'am, he has been given. In fact, he came to the hospital today also and he climbed the stairs. I asked them. They
He
say
cannot climb.
He cannot climb.
so the upper level is the last thing that he can do is that he can walk independently,
Ma'am,
but he cannot run.
cannot run.
So what will the range be then? Yes, anybody else? Shilpa? 12 to 18 months, okay. Maybe say around 15 to 18 months, 13 to 14, 15 to 18 months. Okay. So if we take a crude development, quotient for the motor domain, that would be roughly around. So that would be the motor age, the crude motor age divided by the chronological age. And the chronological age is
Ma'am, 5 years.
5. So that's 60.
60.
So assume 15 by 60. So around 25% crude. This is all crude. We're just trying to look at the pattern here. Then can we go to the fine motor? He can scribble and he can also make a line.
Line
And a circle.
And a circle.
You've seen that? You've checked that?
Yes, ma'am.
Okay. So anybody from the students, what is your interpretation over here? Nee, for the fine motor, was the acquisition normal? So the acquisition was normal from the onset, but was it, are you sure? It was normal initially, then there was a slight delay at around the,
8 to 9 months. 8 to 9. At
No.
reaching out was delayed at 7 to 8 months.
no, the pincer came late.
Reaching out
Re-
was also at 7
reaching
to
out
8
was, no, reaching out was earlier,
3 to 4 months.
3
7 to 8 months.
Reaching
ma'am,
out
7
was
to
4
8
months.
7 to 8 months.
7 to 8 months.
Mm.
Okay,
Holding objects kept in hand was at 3 to 4 months.
okay. So there was a slight delay, but not as prominent as the gross motor. But later on, he kind of has, and the current status is now what crude age will you give for the fine motor?
Ma'am,
He
around
can make a
3
line, he can make a circle,
make a
he can
circle.
copy a circle, so at least around 3 years.
3 years.
So 3 years by 5 years would be roughly around 60%. Okay.
Just one little comment. I wonder if one should, give too much of credit to parents noticing the pincer grasp. We did say that pincer grasp came at 2 years. It's a very specific thing and parents may not have noted it. So saying that pincer grasp is delayed
Ma'am, I'll just
is
digress
a
on this point.
little, yeah.
Because usually what we ask is that we take common things which a child does, like reaching out for a pebble or a cheaty or something like that. And if you ask them that if you demonstrate also, did the child pick up a small object like whatever examples I just gave, and you show the finger and the thumb, we usually do manage to get a answer.
Maybe, they might tell you later than when it actually appeared. They might remember, is age mein to utha leta tha. So for example, if this child, they've noted at 2 years, it is very likely that he actually probably started doing it earlier and it was not really noted. Anyway, this is a thing that you would probably be a lot more sure when you're doing examination. No, you said he can copy a circle. When does a child, is there a difference between copying and imitating? What is the difference? Do the students know? Copying a circle and imitating a circle. So, Sukriti is nodding her head. Can Sukriti tell us? If you can give her the mic. Quickly, quickly.
For the purpose of imitation, we need to draw the circle in front of the child, and accordingly the child has to do the same while we are making the circle. So accordingly he learns, accordingly at the same time he'll try to do whatever we are doing at the same frequency. And whereas in case of copying the circle, we make after making the circle, we provide it to the child and ask him to make the same thing on his own.
So what comes earlier, imitating or copying?
Imitating should come
because
earlier.
he's seeing it and he's given an opportunity to follow those
Follow
movements.
those steps.
Very well said. So this child is able to copy. So
Okay, so now we move on to the next domain, which is?
Social.
Okay.
Social smile came at 1.5 months of age. He started recognizing his mother at 2.5 months of age. Stranger anxiety developed at 10 to 11 months of age. Mother is not able to clearly tell when he started displaying his pleasure and displeasure, but she says around 2 years he started expressing his likes and dislikes for the food. He started waving bye-bye at 1 year of age. He started helping to dress and undress him at 3 to 4 years of age. Currently he can undress himself, but he needs help with buttons. He does not know his gender, he does not know his age at present.
Okay. Although I would have preferred some other questions, could somebody enumerate the questions which he didn't ask? Rattle play would come around, roughly around 6 months, and that in fact is a question which we usually ask to replace the questions which are asked in Western literature regarding looking at the mirror and smiling at the mirror. Because due to cultural taboos, mirrors are often not given or shown to young children. So we use, as a substitute, we use rattle play. And did you mention lap games, peekaboo?
Ma'am, they
You said just waving bye-bye, I
asked
believe,
about
right?
peekaboo and interacting and smiling at the mirror, but there were no opportunities for
Okay.
peekaboo and interacting and smiling at the mirror.
Okay. So what was the, and what about parallel play?
Ma'am, I asked about parallel play. She is not sure, but she says around 3 years of age.
So he can do parallel
He plays
play.
with his peers and his siblings, but
Okay. So he has achieved parallel play and he cannot yet identify whether he's a boy or a girl, because
Yes,
I
ma'am.
believe I asked him in the morning also,
Ma'am.
and he said he was a ladki. So that will roughly come to us, the crude social age would be? Parallel play comes when, Nimisha? Yeah, roughly around 2 years. And identification of gender roughly around
3 years.
So we'd say it's around roughly 2 to 3 years. So if 2 to 3 years by 5 would again be around 40 to 60.
50.
Okay. And then the last domain?
Language, he started cooing at 6 to 7 months of age, monosyllables at 8 months, bisyllables 1 year. First word with meaning at 1 year of age. He started speaking simple 2-word phrases at 2 years of age, and presently he can make 3 to 4 words phrases, but he cannot narrate a story.
Okay. So what, any one of you, did you notice a pattern here? What was the acquisition, the milestones like? Was it normal or was it delayed? It was delayed, but he apparently seems to have caught up somewhere around between 1 to 2. Although I'm not, what word did he say with meaning? Because often parents, if not asked properly, might think that a one-word meaning and a bisyllable is the same.
Ma'am, mummy, mama.
Mamma could have been a bisyllable also.
Yes, ma'am.
Okay, so whatever. So right now, what would we say the crude language ages?
Ma'am, he can make 3 to 4 words. He can speak 3 to 4 word phrases to around roughly 3
Around 3 years.
3 years.
Okay. So 3 years, so that again makes it 3 by 5, so 60. Okay. Right. So we've come to the purpose of doing this is that now we have looked at the profile of this child. So we have the gross motor profile, he's functioning at around 25. The fine motor, he was roughly functioning at around, what was the fine motor?
60%.
60. The social was 40 to 60. and the language is currently 60. So what kind of a pattern is emerging? So although more than 2 domains are affected, but so we will say global developmental delay, but within that also the motor domain is more affected. Okay.
So I think right now we'll take a little deviate from the case and we'll ask Dr. Sharmila to quickly tell you how do you go about taking a developmental history and interpreting it. Can you do it from here?
Yeah. So can you please focus on the slide?
Focus on this, please.
So basically, when we approach a child with developmental delay, I'm just going to tell you the basic steps. You determine the pattern of acquisition, and here what is it? It's a delay. Aniket, is there any history of any loss of any kind of milestone? No. So there is no apparent regression till now. We determine what the current functioning is, which we just did, and we determine the pattern of delay from the profile, which we also did. And what emerged was, next please. So there are basically 3 patterns. I'm sorry, I think it's not very clear, but the first one is predominantly motor delay. The one in the middle, and you can see from the graph below, is that the gross motor quotient and the fine motor quotient is low compared to a normal social and language quotient. And the one in the middle is global developmental delay, in which all 4 are affected. There is no clear pattern. And in the third one is predominantly language delay, in which the gross motor, fine motor and social are affected, and the language is significantly impaired. Can you continue please? Now, if we come to, since in this child we have developmental delay and it's predominantly motor, there are 2 basic causes, neurological, which basically means that there is an insult or a lesion or something affecting the motor axis, which begins with the brain, the motor cortex, then the spinal cord, the motor nerve, the neuromotor junction, then the muscle. And non-neurological problems would be mechanical problems which arise from either bony deformities or joint deformities. So once we do the examination, we listen to, the history is completed and we do the examination, we will be able to identify hopefully which cause is causing this predominant motor delay in this child. So we continue with the rest.
In dietary history, the patient has been on mixed feeds since birth, breastfeeds with cow milk in 1:1 dilution. Semi-solids were introduced at 2 years of age. Presently, he eats from the family pot, takes 3 major meals a day along with 2 snack meals. His total calorie and protein come out to be 1000 kilocalories and 14.2 grams per day, which is calories are 74% of the expected and proteins are 71% of the expected. So
Aniket, can you please tell what is expected for this child, caloric and protein intake, and from where did you take those figures?
Ma'am, ICMR recommendations 1350 kilocalories for this age group and 20 grams of protein per day. In socioeconomic history, the child belongs to lower upper socioeconomic class 4 according to the modified.
Just a sec, there is some calorie deficit. How much calorie deficit are you saying?
Ma'am, 74% of expected he's taking for the age.
And this is on a recall, dietary recall, you've done that?
Yes, ma'am, 24-hour dietary recall.
Okay.
The next is examination, ma'am.
Have you finished with the history? Okay, so at the end of history, what we have is, very quickly, we have a 5-year-old child whose basic parents have got 2 complaints. They feel the child is short, he's not growing well, and secondly, he looks a little unusual. Then Aniket has tried to take a history of causes suggestive of short stature, and then we've also learnt in the rest, and he's really not been able to pinpoint something. We know that the birth and everything seems to be okay. This is a non-consanguineous marriage and there doesn't seem to be anybody else who's affected in the family. We've also learned that the child has a developmental delay and more of motor delay as compared to language and socio-adaptive. Now, having learnt, is there anything else, Preeti? Sharmila, have I missed anything? I think these are the gross things in history. So I think before we go on to the examination findings, we'll just ask Dr. Preeti, when you have a child who's come to you with short stature, what are the key points in history? What will help you go forward? Preeti, can you please?
Thank you, ma'am. Okay. So first, we should know how do we define a child of short stature. Short stature is defined as a height below the 3rd centile, or if it is less than 2 standard deviation below the median height for that particular age and sex, according to the population standard. This is very important, that you have to use the population standard. Or if you feel that the child's height is within the normal centile, still you can label a child as short stature if it is less than the 2 standard deviation of the mid-parental target height. So I'll be elaborating how do we calculate the mid-parental height and the target height, and what is 2 standard deviation of the MPH target height. Okay, now how do we classify a child with short stature? Short stature could be either physiological or it can be pathological. By physiological short stature, I mean the normal variants, that is the familial short stature and the constitutional delay of growth and puberty. The other type is the pathological type, in which we can have proportionate and disproportionate short stature. So if you have a child in the OPD who has come with a complaint of short stature, when do we actually start investigating the child? If you feel that the height is less than -2 standard deviation for that particular age, if the height is less than the 2 standard deviation of the mid-parental target height, as I told you before, because at times it can happen that the height is within the normal, still the child looks short. Number 3rd is if the height velocity, that is the growth velocity, is consistently below the 25th centile over a period of 6 to 12 months. This is very important because when we calculate the growth velocity, we do not calculate from a single height. We have to plot the growth velocity over a period of 6 to 12 months, and hence we can calculate it. And 4th is if there is a downward crossing of percentiles on a growth chart. So coming on to the etiology, as I already said that short stature could be either physiological or pathological. Among the pathological causes, we start from the antenatal period, that is the prenatal causes which cause SGA babies, IUGR and the various genetic syndromes. Then the various chromosomal defects, they can also present like Down syndrome, Turner syndrome, Noonan's. They can also present with short stature. The very important cause and which should be evaluated in every child are the systemic causes, which can cater to the renal pathology in the form of an RTA or a CKD, or it could be because of malabsorption. Very commonly we find children with celiac disease coming with short stature. Then the cardiac, the congenital heart disorders, any hypoxemic condition, anemias, they can also lead to short stature. So it's very important that we investigate the child thoroughly for any systemic cause for short stature. The other causes could be the nutritional causes, calories, protein intake, other minerals and vitamin deficiencies like vitamin D deficiency, they can also present with short stature. Then the endocrinological causes like the hypothyroidism, it should be evaluated in a child with short stature. Other causes could be growth hormone deficiencies, Cushing syndromes, they should also be evaluated if you have clinical pointers for it. Then the skeletal dysplasias, it happens quite frequently that the child presents with skeletal dysplasia and hence he is not growing well. So this also should be ruled out. Then psychosocial deprivation. So in families where you have a lot of children, you can find that child is just not growing well because the environment is not that conducive. His calorie and protein requirements could be normal, or otherwise also in our society we are finding that there are a lot of cases of child abuse. The only treatment for such children is that you remove the child from the hostile environment and you give a conducive environment. In spite of the normal protein calories, these children fail to grow. And lastly, the drugs. The drug history is also very important because steroids, they have a very vital role. They can cause growth retardation. So history is the most important thing. We start from the antenatal period, take a history of maternal infections during the antenatal period, history of drugs, alcohol, smoking. Then coming on to the birth history, it's very important that we calculate the birth weight, length and the gestational age of the child. This is very important because we very frequently find IUGR babies who fail to grow in the later part of childhood. Then developmental history is very important, as in this child also we have a history of developmental delay. Then the accurate calorie and protein requirements, and also vitamin and mineral deficiencies like anemias, vitamin D deficiency, they could be a cause of short stature. It's very important to ask for the onset of puberty in the parents, because in children who have a constitutional delay, it can happen that the parents also give a history of delay in the onset of puberty. Then systemic diseases should be ruled out and investigated thoroughly in every child with a history of short stature. History of drug intake. Quite often happens that there is an Exol present in the brain, and that can also lead to a case, child can present with short stature. What happens is there is a disturbance in the hypothalamic pituitary axis, and hence the child can also present with short stature. Then of course the psychosocial cause, but that should be done at the last. So what are the steps in assessment of a child who comes with short stature? The first and foremost is that the child's age should be evaluated by asking the date of birth. It happens very frequently that the child's age is not ascertained properly, and hence you have all the wrong measurements on your growth chart. So it's very important that you ask and reconfirm the date of birth of the child. Then accurate measurement, that is very important. Like for a child who is less than 2 years, we usually take the length using an infantometer, and more than 2 years we use a stadiometer for recording the height. Then comparison with the population norms. So we have to use the growth charts according to the population, for which we are calculating the, we are plotting our anthropometric parameters. Then the growth velocity, but for growth velocity it is very important that we do a serial measurements. Only a single recording is not sufficient for ascertaining a growth velocity. Then calculation of the child's own genetic potential, because very frequently it happens that children come with the parents have a concern of that the child is not growing well, and probably there is just a constitutional delay or there is a familial short stature. So they need not be unnecessarily investigated, these children. So it's very important that child's own genetic potential should be calculated. Then assessment of body proportions, it becomes very important in children with skeletal dysplasias. So we need to know what is an upper segment, lower segment, how do we actually calculate it, and how do we interpret it. Then all the measurements, all the growth velocities have to be corroborated with the SMR, because we already know that the growth velocity, it decreases from infancy up till childhood, and then again it picks up during puberty. So the velocity of growth, it has to be corroborated with the SMR, and then definitely make a note of the dysmorphic features or any skeletal deformities which are actually visible. They can help us in making a diagnosis. So this is just a, I wanted to tell you how do we calculate the growth velocity. This is an example of a 5-year-old boy who has come with a height of 104 centimeters, and on follow-up after 6 months his height is somewhere around 107 centimeters. So there is a gain of 3 centimeters over a period of 6 months. So the growth velocity would be 6 centimeters per year. Again, this is a normal growth velocity as per the age. Okay, this is very important. How do we calculate the MPH for boys and girls? When we are calculating the MPH, it's very important that we ascertain what is the height of the mother and father. So both should be present. Their height needs to be recorded, and the figure of 6.5 needs to be, actually we take a figure of 13. So when we divide it by 2, the figure comes out to be 6.5. This figure of 13 is added to the mother's height in case of boys, and it is subtracted from the father's height in case of girls. That's how we calculate the mid-parental height. And target height is calculated by adding a figure of 8 centimeters to the mid-parental height, which roughly conforms to the plus minus 2 standard deviation. I'll show you an example. So this is the growth chart of a girl, of 11-year-old girl, of a boy who has come to us, and his height is at 120 centimeters. So it is less than the 3rd centile. So now we go into the plotting the MPH of this child. The mother's and father's height was taken, and the MPH came out to be somewhere around 155. So that's what I have plotted on the right hand side margin. You can see. Okay. This is the right hand side margin in which you can plot this MPH over here by putting an arrow. This has come out to be 155 centimeters, and target height can be marked over a range of 8 centimeters. So we go up 8 centimeters and below 8 centimeters. That is the target height. So the child height can fall anywhere between say 163.5 and below, that is 147.5. So anywhere, any point of the height in between this range is considered as normal for that particular child. So it's very important that we mark the MPH and the target height before interpreting the child, and then we have to serially follow the child by recording the height every 6 to 12 monthly, and we realize that probably the child's height is parallel to the 3rd centile and within the target height. So we need not investigate the child, and we can just counsel the parents regarding the concern of short stature. Now we come on to the body proportions. This is very important because in children with skeletal dysplasias, we often have children who come with short stature. So how do we calculate the body proportions? Firstly, I wanted to tell you that at birth, the upper segment to lower segment ratio is 1.7. So we have a long trunk as compared to the limbs. So the upper segment to lower segment ratio is calculated by first taking the height of the child, and the lower segment is taken by measuring the symphysis pubis to the floor. So upper segment is calculated by subtracting this figure of lower segment from the height that will record the upper segment. So at birth, the upper segment lower segment ratio is 1.7, and gradually as the child grows, the upper segment ratio keeps on decreasing. That means the limb length keeps on increasing and the trunk does not increase that much. So at around 7 to 10 years, this upper segment to lower segment ratio equalizes to 1. So that is the normal upper segment to lower segment ratio. Now, in various disorders, you can find that the upper segment ratio is more than the lower segment ratio, like in rickets, achondroplasias, and hypothyroidism. In disorders which are affecting the spine, this ratio gets decreased. So, in certain children, it happens that you are not able to accurately measure the upper segment. For this, we can use this parameter of sitting height. What do? We make the child to sit on a stool so that the thighs are parallel to the ground, and we take the sitting height of that particular child, and then we calculate the ratio of this sitting height to the total height. So we have these charts available for the median of boys and girls of the ratio of the sitting height to the standing height. Again, we have a parameter of arm span. How is it calculated? It is the distance between the distal ends of both the middle phalanges while the patient stands against a wall with the arms outstretched, and the arm span is shorter than the height in boys before 10 to 11 years and in girls before 10 to 14 years, after which it exceeds the height. This particular proportion, that is shoulder to elbow, is to elbow to metacarpal ratio, is calculated in cases where we have disproportion in the limb length. So what is done is we ask the child to sit with the elbows flexed, and we take a point bony prominence from the shoulder to the elbow joint, and again from the elbow joint to the third metacarpal, and we calculate the length of both these segments. The normal ratio is 1, and in rhizomelic shortening, the ratio falls to less than 0.98. So to summarize, what are the causes of disproportionate short stature? We can have short limbs or the short trunk. Among the short limbs, the causes would be achondroplasia, hypochondroplasia, metaphyseal chondrodysplasias, refractory rickets. So in all these conditions, the limb length is less as compared to the trunk. But in short trunk causes, the spine is affected. So we have causes like MPS, that is mucopolysaccharidosis, mucolipidosis, then spondyloepiphyseal dysplasias, KD spine, and heavy vertebrae. Thank you,
Preeti. That was a very, very quick refresher on how do you approach a short child. I'll just add a few comments in context of this child. What she has given you is overview. One, Dr. Preeti mentioned that you should be using local reference standards. That is important. So what I would tell all the postgraduates is, when you are comparing growth of a child up to 5 years of age, please use WHO growth reference standards. These are multi-country standards, and India was part of the group which contributed to that data. So up to 5 years, we should be using the WHO growth reference standards. Beyond 5 years of age, it is better to use your own country standards, and we have a lot of growth reference data from our own country. The older ones were by Dr. K. N. Agarwal. We also have some recent studies which have come up, and very, very recently during this Pedicon, the Indian Academy of Pediatrics released its own composite growth charts, and these growth charts are actually derived from amalgamation of data from multiple studies in the country. So that would be good. It is still too early for it to appear in your textbooks, but that article has already appeared in Indian Pediatrics 2015 January issue. I would request all of you to take that article. It will be good to use that reference data for children beyond 5 years of age. Okay, so that's message number 1. Number 2, Dr. Preeti showed us a slide where she gave indications of evaluating a child for short stature, and she mentioned growth velocity. Growth velocity would be good to monitor in a child who is, maybe just a little below 3rd centile, and he's falling within the mid-parental height centile, so you follow up and see how the child is doing. But if a child like this comes to you who has such extreme short stature, एक बार बच्चे को जरा दिखाइएगा दोबारा से. This is a 5-year-old child with this kind of extreme short stature. You don't have to wait for growth velocity. You go ahead with a full evaluation straight away. Okay? So हर बच्चे में जरूरी नहीं है. It's not important that we look at the growth velocity. Okay? So in fact, when you have among all the causes that Dr. Preeti told you about short stature, this is so short. He is 5-year-old and is so short. In such a child, please go ahead with a complete evaluation at the first go itself. Next is when you deal with such a extreme short stature, a lot of causes get excluded. So even though in our own experience, a whole lot of short stature is because of systemic diseases. Okay, so chronic systemic diseases like celiac disease, like cardiac disease, like pulmonary disease constitute the most important causes of short stature. But when you deal with such a severe short stature, those causes become a little unlikely. More so if the child also has dysmorphism, which is pretty obvious in this child. So such a child, of course, we might still do as a routine in history, as Dr. Aniket has taken, you would take histories of systemic diseases, but practically this child is very unlikely to be having these kind of features. So when you have extreme short stature, there are two groups of disorders you must think of. One, you must think in terms of skeletal dysplasias, and there are a whole variety of diseases which can cause skeletal involvement. And secondly, endocrine causes. Endocrine causes are another group of disorders that can cause extreme short stature. So these two groups you must consider. Third is something that Aniket, of course, will tell us the examination findings. Relative involvement of weight and height gives you a very valuable clue as to what you are dealing with. So if you are dealing with, say, something like endocrine cause of short stature and skeletal dysplasias, the child is short, the weight is usually well maintained. When I say well maintained, it is well maintained for the child's height, not his age. So in other words, his BMI or weight for height would be near normal. Whereas if a systemic disease like, say, renal tubular acidosis, like CRF, or like a chronic cardiac disease is causing short stature, then generally weight is at least as much or even more severely affected. So you expect those children to have a low BMI. Is it making sense? So that's a very kind of a gross indicator that this child is likely to have systemic disease and this one is not. So with this kind of a background, we ask now Aniket to, I think you have a question? Dr. Sharmila has a question before we go on with the examination.
Okay, I have a question addressed to the PGs. So I'll ask one of the EGPGs, can Prabjot answer this question? My question is, because I often encounter this when I'm taking cases with you guys. If you have a child who is short, right? I mean, suppose we have a child whose height 50th percentile is 100 centimeters and he is 82 centimeters. When will you call it short stature and when will you call it stunting? How will you decide that?
Ma'am, we take the percentage of the height as compared to the median which is expected for that height. In case it is... So
for this child, then why are we using the term, will we use the term short stature or will we use the term stunting or will we use both the terms?
Ma'am, we will use the term short stature because, ma'am, he is less than the third centile for his age.
Why not stunting?
Less than 2 standard deviation is called short stature, less than 3 standard deviation is called stunting.
No. Okay, so what?
Less than 80% of the height for age is called short stature.
Less than 80% of the. No, incorrect.
Short stature is a blanket term and stunting refers to those causes of short stature which are because of nutritional causes.
Okay, good. So when you're, like what ma'am said in the last, that usually when the weight is also affected due to systemic diseases. So when you're attributing a nutritional cause to the short stature, to the shortness, then you use the term stunting. In which case then you use the 50th percentile and you derive it from there. But in a case like this, where it is not nutritional, it is definitely some other cause, then you will use the term short stature. And ma'am would please clarify.
Thank you, Sharmila. You raised a very important point. I'll just add one thing. Why do we use WHO defined stunting based on current height? You're very right. But remember, terms like wasting and stunting are limited only to first 5 years of life. So if a child is older than 5 years, we don't use the term stunting. Though it's not that a child beyond 5 years cannot have nutritional stunting. That is not true. But the fact is, if you see the growth velocity is extremely fast in the first 2 years of life. So a lot of stunting actually starts manifesting around 2 years of age. In fact, you would have heard the importance of first 1,000 days of a child's life. Because if the child has nutritional issues there and any growth deficit is encountered, it doesn't get covered up, right? That is why stunting, so stunting basically refers to a short stature secondary to nutritional and related causes. For example, repeated infections in a child would again lead to a calorie deficit and therefore causing stunting. And because short stature, because of nutritional and related causes, is so much more common in children under 5 years of age as compared to other causes of short stature, which become more obvious as the child grows older. So standardly you would say, okay, stunting is height less than say 90% of the median or less than -2 standard. So it is 90% and not 80% as you were saying. Less than 80%, in fact less than 80% would be severe stunting. -2 standard deviation and -3 standard deviation. But as the child grows older, more and more causes apart from nutrition become important for short stature. So short stature is a blanket term. Stunting refers to it when short stature is attributed to nutritional causes. Okay, are we clear on that? So go on with the examination.
On examination, the child is sitting comfortably in chair and he appears interested in his surroundings. The pulse rate when I examined the child was 100 per minute, regular, rhythmic, good volume. All the peripheral pulses are palpable. There is no radial or radiofemoral delay. The respiratory rate is 26 per minute, regular, thoraco-abdominal, no use of accessory muscles of respiration. I had taken the BP in all 4 limbs. There was no significant difference between the upper limb and lower limbs. The BP in the right upper limb taken in supine position was 90/40. He has wide pulse pressure, and this is between 50th and 90th percentile for his age, sex, and height percentile charts. The capillary refilling time is less than 3 seconds. Jugular venous pressure is not raised. Saturation SpO2 is 99% on room air. Coming to anthropometry, the weight is 11.4 kgs, which is less than 3rd standard deviation for the age and is 71.25% of the 50th percentile according to the Agarwal charts. The height is 82 centimeters, which is less than 3rd standard deviation, 73.8% of the 50th percentile. The head circumference is 45 centimeters, which is less than 3rd standard deviation. And 88% of the median according to the age of the child. But if we consider the length of the child, the length age comes out to be around 20 months, and this head circumference comes at exactly -2 standard deviation for the length age of this child. The upper segment to lower segment ratio is 0.935, which is less for this age group. The sitting height is 44.5 centimeters, which is 54.27% of the total length of the patient, and the normal for this age is around 56% according to the charts which have been already discussed. The BMI of the patient is 17.01 kgs per meter square, which is between 85th and 95th percentile.
So Aniket, can you please give interpretation of your anthropometric data?
Ma'am, the child has short stature as the height is less than 3rd standard deviation, but the BMI is between 85th and 95th percentile. So we see here that the height is more affected than the weight of the child in this case, and there is head circumference. If we take into account only the age of the child, then the head circumference is fulfilling the criteria for microcephaly. But since the stature of the height, the child is short, we have to consider the length age, which is 20 months for this child.
You mean height age, not length?
For the height age. And according to that, the child does not have microcephaly.
Okay, and you also had said something about upper segment, lower segment ratio. What's your comment on that?
Ma'am, as we have already seen, the upper segment to lower segment ratio is 1.7 at birth, and around 6 years of age it is 1.1, and for this child it is 0.935. This is short for this age group, so he has a short trunk, disproportionate.
So one point important that I would like to reiterate what Aniket has done, and something that I see postgraduates often miss doing. See, this child has extreme short stature, right? So what we have, what he said is he meets the definition of short stature, height less than -2 standard deviation. What is important is that we must, in a child with this degree of short stature, exactly quantify how much less than -2 standard deviation. So otherwise, so one simple way of doing it is taking it percentage of median as he did it. So the further it is, less it is as a percentage of median. Another way, so this is a good way when you're doing your clinical evaluation. Same goes for weight. If you're dealing with, say, a child with, say, severe acute malnutrition and the child has really low weight, don't just say that the weight is weight for length is less than -3 st. Good idea to say how much percentage of median so that you know how much further it is. Less than -3 could be, just a borderline less than -3 or way less than -3. So good idea to say that. Another way is, which you can't do maybe for your clinical case discussion, but otherwise the patient admitted in the ward, you could always look at the Z scores. Z score can again be calculated and Z score would give you the same information. How many Z scores is the child's weight or height or BMI for that matter away from the median. That's another way of doing it. Okay. So Aniket has told us both height and weight as percentages of median. So we know height is way below the median and weight for height or BMI is relatively well maintained in this child. So keep these factors in mind when we make our differential diagnosis. Carry on.
On general physical examination, there is no pallor, icterus, clubbing, cyanosis, pedal edema or lymphadenopathy. On head-to-toe examination, the hair are black, normal in texture, no areas of baldness. There is a palpable ridge at the site of lambdoid suture suggestive of craniosynostosis. No other suture lines are palpable. The skin is thick and inelastic. The glabella is prominent. There is proptosis, depressed nasal bridge, broad and short nose, anteverted nostrils, long philtrum, large tongue with thick lips, small teeth, and there is crowding of teeth in the lower jaw. There is thick ear cartilage and short neck. In the trunk, he has protuberant abdomen and umbilical hernia is present. Other hernial sites are clear. The hands have short and stubby fingers and clinodactyly of bilateral fifth fingers are present. The knees have bilateral genu valgus deformity. Feet have short broad toes and overlapping toes are present. On per abdomen examination.
Just shown the pictures. We did not want the child to feel embarrassed by undressing him in front of everybody. So we've taken the parents' permission and taken the child's pictures so that all of you can see what he looks like undressed.
On per abdomen examination, on inspection, the abdomen is distended, symmetrical in shape. Both sides are moving equally with respiration. Umbilicus is central. Umbilical hernia is present. There are no other visible scars or veins. Inguinal sites are clear and the genitalia are normal. On palpation, the abdomen is soft, non-tender. The liver is palpable 5 centimeters below the costal margin in mid-clavicular line. Left lobe of the liver is palpable 4 centimeters below the xiphoid process. The surface of the liver is smooth. It has smooth margins. It is firm in consistency and non-tender. The liver span is 10 centimeters. The spleen is palpable 2 centimeters from the left costochondral junction along the splenic axis. It is firm in consistency. No notch is palpable. It is non-tender. No other mass lump are palpable. No free fluid. On examination of the CVS, on inspection, there is a precordial bulge. The chest is symmetrical in shape. Apex is visible just below the nipple. No other visible pulsations or prominent veins. On palpation, the apex is palpable in the fifth intercostal space in the mid-clavicular line. It is localized. No other palpable pulsations, thrills or heart sounds are present. On auscultation, the S1 is, first heart sound is soft, second heart sound is normal. There is a grade 3 pansystolic murmur, best heard at the apex with the diaphragm of the step in left lateral position with radiation to the axilla and the back. On examination of the locomotor system, there is a kyphotic gibbous deformity involving the lower thoracic and upper lumbar vertebrae. The range of motion of the spine appears normal. There is no visible deformity at the shoulders. The range of motion at various joints in the body are limited. I will discuss them in detail. The range of motion at the shoulder in abduction is from 0 to 100 and on both the sides, and it is limited, and in flexion also it is limited to 0 to 90 degrees in both the sides. On internal rotation it is 0 to 45 degrees and both the sides, and on external rotation it is 0 to 60 degrees on the right side and 0 to 45 degrees on the left side. It is more limited on the right side. On elbow examination, the extension is present from 0 to 100 degrees. It is a little limited in flexion on both the sides. Ma'am. On wrist examination, the flexion is again limited, 0 to 70 degrees on right side and 0 to 80 degrees on the left side. On extension, it is 0 to 20 to 30 degrees on both the sides. On finger examination, there are fixed flexion deformities on metacarpophalangeal, proximal interphalangeal and distal interphalangeal joints. All three joints having fixed flexion deformities of around 10 to 15 degrees. On examination of the hip, there is range of motion in flexion is from 0 to 70 degrees on the right and 0 to 80 degrees on the left. In extension, ma'am.
We're going to proceed with demonstration of the range of motion. While we're organizing that, I'd just like to tell the PGs that in a child like this or any kid with this kind of a problem, you need to do two types of range of movements. One is active and the second type is passive. Can anyone tell me what the difference is between both? Chaitra? Active is?
To what extent the child can do by himself.
Okay, very good. So active is when the child is doing it by himself.
Passive is when the examiner is trying to demonstrate.
Right. So passive is when the examiner does it, and often like we face this problem with this child, we couldn't get him to do the active range of movements, although we use lots and lots of incentives, but passive we could. And what Aniket has just told us is the passive range of movements. And you need to do it for the upper limb, the shoulder,
रेंज ऑफ मूवमेंट हाँ देखो ऊपर कर ले बेटा हाथ ऊपर कर ऐसा कर ऐसा कर
We are right now checking for the active abduction of the shoulder joint. As you can see, it does not go beyond around 100 degrees. At neutral position, it is taken to be 0 degrees.
So this is the range of abduction. So you can see that there is limitation. The child cannot do overhead abduction. Okay. Then the flexion. And the extension. So there is limitation in range of movement of the extension. Then internal and external rotation. Now at the elbow joint, we have to look for extension and flexion. So flexion is restricted and even the extension. So you can see that the child cannot flex beyond this point and even the extension is limited. At the wrist joint again, we'll do flexion and extension. Bas beta, bas, nahi ro nahi. So there is limitation of movement again at flexion and extension of the wrist joint. Then at the distal interphalangeal joints, there is again restriction of movement, both of the extension and flexion. More of the extension and less of flexion.
lower limb का बिठा कर सकते हैं. You can make them sit here at least knee or ankle. Don't the part is upper limb थोड़ा सा कर जितना because he is getting better. यहाँ पर बैठ के कर बैठ जा शाबाश हाँ लोअर लिम्ब कर अभी जैकेट दे अभी जैकेट ना ऐसे शॉल के साथ लोअर लिम्ब
making him lie down.
लोअर लिम्ब का नी का जितना दिखा सकते हो बैठे बैठे दिखा नहीं so you can show it is normal
So in the valgus deformity. Okay, again we have to check for the range of movements at the hip joint, knee joint, ankle joint. So we have to do maneuvers to do that. We have to make the child lie down and look for extension and flexion at the hip joint. And on doing that we had
थोड़ा सा लेटोगे यहाँ पर
लेट जाओ
थोड़ी देर के लिए
लेट जाओ मैम,
एक मिनट के लिए प्लीज
लेट जाओ
थोड़ा सा लेट जाओ प्लीज सिर्फ एक मिनट के लिए
लेट जाओ
एक
बाबू,
मिनट के लिए
अभी चलेंगे।
बस आपके पास में है बस कुछ नहीं करेंगे बेटा बस शाबाश इसको बंद कर दें ठंडी लगेगी आप इधर आ जाओ नीचे थोड़ा इधर आ जाओ कहाँ से आप ले रहे हैं यहाँ से ले रहे हैं तो फिर पीछे बस
The range of motion at the hip is from 0 to around 110 degrees. For extension, it was from 0 to around 20 degrees.
अच्छा ठीक है बस सिखा रहे हैं।
हाँ बस अभी
This is for knee extension.
बस बेटा बस
ठीक है अच्छा ठीक शाबाश चल तू बैठ के टेल कर I think we'll listen to the rest of it from Aniket. The child is getting apprehensive, but the whole idea is to say when you have a child like this kind of dysmorphism, this kind of short stature, it is important to check the range of movement. In fact, we should admit here when the child was first seen, the contractures were missed, and it was only when the child was made more comfortable and after he was in the ward for a long time and then the child was re-evaluated when he was more comfortable, we picked up these contractures. So sometimes that happens, and certainly there's nothing to be gained by agitating the child and losing his trust. So we'll listen to Aniket for rest of the examination findings.
We have already demonstrated till the hip, and the knee has range of motion from 0 to 150 degrees. On ankle and dorsiflexion it is from 0 to 30 degrees on both the sides, and in plantar flexion it is from 0 to 40 degrees on both the sides. On examination of the chest, on inspection, the shape is symmetrical, both sides are moving equally with respiration, and there is no evidence of increase in work of breathing. No visible scars, sinuses or fistulas. On palpation, the trachea is in midline. On percussion, bilateral normal resonant, the chest is normally resonant on both sides. On auscultation, bilaterally air entry is equal, normal vesicular breath sounds are heard, and there are no added sounds. On the examination of the CNS, the child is conscious, alert. In general behavior, the child is sitting comfortably, he is interested in his surroundings, he is oriented in place and person. His attention span could not be tested as the child is not cooperative. In speech and language, he understands simple commands, speech is fluent, but there is some difficulty with articulation. The naming was not tested as the child is not cooperative. The memory was not tested. In intelligence calculation, he does not do simple calculations. Abstract thinking could not be tested. The cranial nerve examination is normal. On the examination of the motor system, the gait, he has a weight-based stance and there is stiff and unsteady gait. The bulk appears to be normal. The tone appears to be normal in all four limbs. The power is at least 4/5 at all the joints. The DTRs are present and the plantars are downwards. Sensory system could not be tested in detail as the patient is not cooperative, but it appears to be normal. There are no cerebellar signs or no signs of meningitis.
I think, Aniket, you could not get a more cooperative patient, so let's be very clear about that. And I don't think anybody would get a child who is more cooperative than this. You've had enough opportunity. And yes, grossly, of course, if you can't expect a child who already has some degree of global developmental delay to be doing tests like 2-point discrimination tests and vibration, those things you don't expect. But grossly, is the sensory system normal? That is what is important.
Yes,
so you must only be commenting on what is doable and not what is undoable. You can't really expect a child to do beyond what is capable of and say that the child is uncooperative. No, that doesn't happen. Yeah.
My examination is complete.
I think key examination findings. So what have we learned from this child's examination? What I have learned is that this child seems to have vitals are stable, very alert, active, happy child if you are not bothering him. But he has a wide pulse pressure, and so keep that in mind. He has a wide pulse pressure, but no other evidence of CHF or no chronic systemic disease. He has marked dysmorphism, and some of it is pretty obvious, and Aniket has explained that in detail. He appears to have a very obviously a very prominent eyes, a prominent nose, broad philtrum, obviously short stature, and he has a degree of contractures, multiple joint contractures. And then he also has hepatosplenomegaly.
Yes, ma'am.
And he has, his cardiac evaluation reveals a pansystolic murmur best heard at the apex, which probably looks like a mitral regurgitation
Yes,
murmur.
ma'am.
What do you say?
Yes, ma'am.
Okay, so these are, and CNS examination grossly seems to be alright, apart from the contractures, his bulk, power, tone, cranial nerves, everything appears to be normal. So, having said that, I think we'll take again a detour, and since this child has so much of dysmorphism, sometimes students get confused as to how to go about approaching a child. So, we'll ask Dr. Sharmila to quickly take you through, when you have a child with dysmorphism, how do you go about approaching such a child?
Thank you, ma'am. So, a child who is dysmorphic is basically a child who has physical features usually not found in a child of the same age or ethnic background. And the first rule is that you must look at the parents and the siblings. Although sometimes the child may be suffering from a disease which has a variable penetrance, and the parents may also be affected. But you need to look at the entire family. The approach in terms of history is, the salient things which you must look for is systemic involvement of any system which may kind of highlight any system which is being affected, and that may be pathognomic, or that may be a common association with a particular syndrome. The family history, third degree, pedigree, developmental milestones, antenatal history, especially quickening, fetal movements, exposure to teratogens, the presence or absence of oligohydramnios or polyhydramnios. Examination, we look for the anomalies. I'll be going into that. Then you synthesize, which means that you compile all your findings together and try to arrive at a differential diagnosis. And according to whatever differential diagnosis you arrive at, you plan the investigations. So when you do the examination, you start from the head and you go downwards. So you have to look at the face, and when you do the examination of the face, you kind of divide the face into the upper 1/3, which is from the upper orbital ridge till the forehead, then the middle 1/3 and the lower 1/3. So the reason we do that is that then you don't miss out anything. So then you do the face, you do the skull and the spine, you do the upper and lower limbs, skin and hair, musculoskeletal system, genitalia, and a detailed systemic examination. Now, I'll just give you a brief background because that will help in understanding when I elaborate further. When you come across an anomaly, you have to decide whether it's a major congenital anomaly or a minor congenital anomaly. The former is anything which is uncorrectable or remains uncorrected and leads to significant functional impairment or leads to reduction in the life expectancy. And a minor congenital anomaly is something which primarily has cosmetic significance, and normally even in a normal population less than 4% may have some kind of minor congenital anomalies. So further, the next thing which you need to see is that, is it an isolated single anomaly or are there multiple anomalies? And why is that important? Like most of the anomalies, if you can see here, this green part, if you compare the green and the top blue on the left hand side, most of the anomalies are isolated and just a few are multiple. If they are isolated, they can either be a deformation, a disruption, dysplasia, or malformation, and I'll be just briefly telling you what these are. And if they are multiple, it can either be isolated, association, it can either be an association, a complex, sequence, syndrome, or none of the above. So what do we mean by when we talk about the single defects, what do we mean by a deformation? A deformation, for example, like a clubfoot, this is basically an alteration of the shape or the structure of any organ that has differentiated in utero normally, but later on has got affected by some kind of abnormal mechanical pressure. Okay, for example, that happens when you have oligohydramnios, or you have twin pregnancies, or you have uterine abnormalities. A disruption is when the structural defects are due to destruction of normally formed and differentiated structures, but they suddenly get disrupted by agents like a congenital infection or amniotic band or some vascular interruption. Then you have a dysplasia. Dysplasia is a structural defect which is due to abnormal cellular organization in the tissue. So in the first and the second ones, they were normal, and then something happened. But here, from the beginning, there is an abnormal cellular organization, and this is due to usually mutant genes which are affecting the intracellular pathways. And a very common type of dysplasia is hypohidrotic ectodermal dysplasia. And the last is the malformation, which is an intrinsically prenatal abnormality of development of a structure. Again, there's abnormal cell proliferation, migration, differentiation, or programmed cell defect, like a wedge vertebrae. Now, when we come to multiple anomalies, you can have a sequence, and a very common sequence is the peri-Robin malformation. So basically, this is a cascade in which one single event leads to sequential structural changes. Then the second is an association, commonly like Vactral. Can you mention any other association which you know of? Charge, okay, great. So these are basically non-random combination of anomalies, and the individual components occur more frequently than by chance, and all anomalies of the association may or may not be present. Then you have a complex, and the complex, for example, is Omens, which is another name for hemifacial microsomia. The anomalies affect different structures, and all the organs which are affected at the same time during embryogenesis in utero. And then you have a syndrome, and syndromes are something which is basically a recognized pattern of congenital anomalies, and there's a unique combination of features which set it apart from other patterns. And a very common syndrome would be Down syndrome. So steps in a dysmorphology evaluation would be, first you need to suspect. We often get lots of kids who may have subtle dysmorphism, but you kind of get the other problems, the systemic problems, kind of overshadow the dysmorphism, and the dysmorphism is not picked up or detected. So you need to have a very strong suspicion, and you need to decide whether it's a normal variant or whether it's an unusual feature. Then you take a history, the way I've outlined before. Then you do the examination, and in the examination, always compare the right side with the left side, and compare the findings with the siblings and the other family members. Assess, document, measure whatever is measurable, and all these things have normative, or not all of them, but quite a large number of these anomalies have normative data which is available, and you need to compare with that to see whether it is normal, unusually large, or unusually small. Then you synthesize, and synthesize, as I told you, we decide whether it's according to whether it's a single anomaly or whether it's a multiple anomaly, which category does it fall into. And according to whatever differential diagnosis you make, then you decide the investigations. Investigations will also need to be done to look for concealed abnormalities. So obviously, like in this child, you have overt features, but we will have to get, although we are going to get an echocardiography done in this child because he has anomalies, but because he has a murmur, but even if he didn't have a murmur, we would still have got it done. So all the things like an X-ray of the spine, hearing assessment, ophthalmic assessment, ultrasound, echo, is to look for all the other clues to see whether you have other anomalies. So it may not be an isolated anomaly after all. You may be having other multiple anomalies which are otherwise not apparent. So when we investigate, I told you about the investigation. The next thing is arriving at the differential diagnosis. So you basically have two groups. One is a common syndrome, like obviously when you see a child with a Down syndrome, you don't start thinking, acha ye kya hai, hame kya investigate karna hai, and things like that. So what you'll do is that you'll plan the investigation for confirming the diagnosis. You know Down syndrome, I need to get a karyotype done. And you will also say that, okay, it's a Down syndrome, I need to get a thyroid function test done, I need to get an echo done, because you know what the associated complications are, and you look for them. Now, on the other hand, and our child over here also has a very typical phenotype, which Aniket will be discussing later. Then you have on the other side, you have uncommon or unknown syndromes, unknown to you, in which you need to consult with an expert. You can also, nowadays, you can just feed in the findings on the internet, do a Google search, and you have various websites like OMIM and Orphanet, and often you can get findings, you can get your diagnosis like that without even having to talk with an expert. There are certain customized softwares like London Dysmorphology Database and POSSUM, in which there's, you can usually arrive at a conclusion. Maintain all records and photographs of the child, and you need to constantly follow up, because sometimes you may not be able to pick up the diagnosis initially, but as the child grows and as the course continues and it evolves, certain other things do become apparent which are pathognomic, and then you can arrive at a diagnosis. And just to end, in kids who have unknown syndromes or uncommon syndromes, often you may not arrive at a diagnosis at all, however much you have tried, however many experts you have consulted. So this is important because the genetic counseling has to be done accordingly. So I'll just, we'll continue, and maybe now we'll summarize the case. So Aniket can summarize the case.
This is a 5-year-old male child with complaints with parental concerns of short stature and unusual looks with developmental delay, with the following findings on examination: disproportionate short stature, short trunk, coarse facial features, umbilical hernia, short stubby fingers of the hands, short broad toes, bilateral genu-valgus deformity with multiple joint contractures, hepatosplenomegaly, and on CVS examination pansystolic murmur and wide pulse pressure. My complete diagnosis is short stature with global developmental delay, with dysmorphism, with hepatosplenomegaly, with valvular heart defect, most likely mitral regurgitation.
Okay, so having said that, what is your differential diagnosis?
Ma'am, first differential diagnosis is storage disorders, most likely one of the lysosomal storage disorders.
Okay, so you have made a relatively rare group of disorders as your first diagnosis. Do the students here agree with the diagnosis made by Dr. Aniket? If anybody does not agree, raise your hand and then we will discuss. So everybody seems to be in agreement. I think my main concern is, putting together everything, it does seem that lysosomal, one of the disorders, of course, lysosomal storage disorders comprise of a wide variety of disorders. But first thing, honestly, when I just looked at this child, before we did a complete evaluation, the first thing that occurred to me was, is it hypothyroidism? So this is something I wanted to tell the students, that when these kind of patients walk into your OPD, you must think of hypothyroidism as well. A severe untreated hypothyroidism would have as coarse facial features as this child has, and closely resembling the lysosomal storage disorders, which can have these kind of coarse faces. And that's a disorder not only more common than lysosomal storage disorders, that's a disorder that is readily amenable to treatment, and that's a disorder which with every delayed day in picking up, the prognosis worsens. So for all these reasons, we need to pick up this disorder early. Having said that, with this first impression, when we evaluate the child, I totally agree with Aniket and that the presence of hepatosplenomegaly, the presence of joint contractures, the presence of mitral regurgitation do make a diagnosis of congenital hypothyroidism highly unlikely in this child. Sharmila and Preeti, if any comments on this?
I want to ask Aniket something that you said with dysmorphism, like now we've elaborated upon all the abnormalities. Would you like to kind of narrow it down to a particular phenotype? Which is probably the reason why you have arrived at the lysosomal storage disorder?
Coarse facial features with visceromegaly.
Does that have a name? Something?
Hurler phenotype.
Yes. So what we're talking about is the Hurler phenotype. So the Hurler phenotype is what is the nomenclature which is used. And could you just elaborate upon what all the what features comprise the Hurler's phenotype?
Comprises of
bilateral corneal clouding. Okay, may or may not have corneal clouding.
Coarse facial features.
So stark, the first thing is coarse facial features.
Deafness.
Deafness.
Abdominal hernias.
Okay.
Visceromegaly.
Okay.
Developmental delay and mental retardation.
Okay.
And radiological changes
okay.
of dysostosis multiplex complex.
Okay. Then short stature.
Short stature.
Okay. Anything else? Are we missing anything over here? Anybody? Joint deformities, yes. What about the face? What is typical about the face? When we said the coarse facies, so you'll have prominent eyes. The reason why you have prominent eyes is because the orbits are shallow. Because the orbits are shallow, the eyes kind of become very prominent. You have this typical anteverted nares. You have a depressed nasal bridge. You can see it in this child. It's depressed.
Can you show that picture? Face.
You have very thick lips, both upper and lower lips. You have macroglossia.
Facial features.
Right? So you can see here these are very, very, very common. I mean, these are very apparent. And as ma'am said very correctly is that they can, if you look at the face, they can, I mean, just the face, you can easily mistake it to be a untreated hypothyroid kid. But because of the visceromegaly and other stuff, it becomes a Hurler phenotype. And that is why we come to the differential diagnosis, which would be?
Various lysosomal disorders like mucopolysaccharidosis. In this case, most likely type 2, because the patient does not have corneal clouding. And other lysosomal storage disorders like oligosaccharidosis, sphingolipidosis and mucolipidosis.
Okay. So how will you investigate this child to confirm your diagnosis?
Ma'am, for confirming.
Any questions from the students so far in history, examination and the basic what he has covered so far?
Can it be type 1? Because the whole Hurlers can be of different spectrum. You can range from Hurlers to Hurler sheets.
I think you made a very, very important point. Could it be type 1? What I would say is he has given a list and he said most probably type 2. But one thing we all need to keep in mind is that all these disorders have a wide spectrum. All of them have a spectrum, some severe to a mild one, and all these disorders have overlapping features. So at most you can say that this seems to be the most likely, and you may be wrong. So it is important to keep a broad mind, and because spectrums are known, variations are known, and overlaps are known. So you can definitely not say that it cannot be one. In fact, we ourselves went through a lot of careful and heated discussion as to where it fits in well. So that's quite okay, a very valid point.
I'd like to add something else, that there is a table available which he'll be looking at later on, in which you have some common features, and within those common features also, like A, B, C, D, whatever, some are common to all and some are absent of one or two. So if you have 2 or 3 features like that, it's a little, I mean, you can kind of narrow it down, but as ma'am said, you have to then do the screening and then go accordingly.
Actually, what is needed is put together everything first of all, make your differential list, and then compare. That kind of exercise is needed. So first put together everything, maybe do a net search, do your book search, narrow your differential, do the relevant test. We call it problem-oriented medical record. So make that. So these are my differentials. For example, congenital hypothyroidism is my differential. I'm going to do a TFT. MPS is my differential. I'm going to do a skeletal survey and I'm going to do a whatever test he's going to tell us. I'm thinking in terms of mucolipidosis, let me look at the cherry red spot. So you're going to make a plan accordingly. So that's how you normally do. And then you keep on ticking and narrowing as you move down, as the reports become available to you. Aniket.
Ma'am, specific investigations for the diagnosis in this patient will be to do a skeletal survey to look for specific changes of MPS, and urine sample for gag repeats. Gags like dermatan sulfate, heparin sulfate are increased in different mucopolysaccharidosis, and they can give a clue. These are only screening tests, and the final diagnosis is made only on doing assays for the specific enzyme defects, and a fundus examination to look for cherry red spots. For diagnosis, I think these investigations.
You can confirm your diagnosis by something else apart from an enzyme activity level. What would that be? Anybody? Ambli?
Apart from enzyme assays, what else? See, what is the cause of these defects?
So genetics, so obviously mutation, right?
To do mutation studies as well.
And Sukriti, he said something about a screening test, right? An MPS screening test. So is an MPS, a positive MPS screening test always correct, or do you have false positives? Can you take the thing, the mic?
We do get false positives in case of mucopolysaccharidosis, that is urinary gag can be present without mucopolysaccharidosis in case the urine is very concentrated, or in case of younger child less than 1 year of age.
Your mic is not perhaps working. Is it switched on?
So you said one, that the child may be less than 1 year old.
Yes.
And the second, the urine may be very concentrated. Any other instances?
Taking spot urinary samples where the diagnosis may be wrong, we preferably should take a 24-hour urinary sample.
Okay, so if a 24-hour urine sample has not been collected? Okay, so just having a screening test positive, an MPS screening test positive, does not necessarily indicate or imply that it's a definitive MPS. You need to go to the next step. Right, Aniket,
Having
continue.
said that, Aniket, can you tell us a urinary gag report of this child? Do we have the report?
We don't have it, but we asked in MAMC. It is positive for urinary gags.
Okay, so
We don't have the final report
He has not
yet,
been
but
given the report as yet?
No, ma'am.
Okay, so we called up the lab and we found out that the report for urinary gags in this child is positive. Okay. And can you show us the skeletal survey of this child?
Sure, ma'am. This is a X-ray of the hands. I can discuss the various features which we can find, and then we can discuss the X-rays. The earliest bone changes are ovoid vertebrae and wide ribs. Other than this, we can have thick skull, sala abnormalities. We can have anterior beaking of the vertebrae. I already mentioned ovoid vertebrae. In hands, as we can see in this X-ray, we have the bullet-shaped phalanges and the proximally pointing metacarpals.
Light off kar dena,
In this X-ray of the spine, we can see one of these vertebrae has an anterior beaking. It has been marked. And the features which we can have on X-ray pelvis are the flaring of the iliac bones and shallow acetabulum. We have both these features in this patient. But the X-ray skulls, we have cardiomegaly in X-ray, but the ribs are normal. They are not broad or as classically has been described, oar-shaped. And even the X-ray skull appears to be normal, and there are no abnormalities of the sala.
Okay, just like, so a constellation of all these radiological signs basically is called
Dysostosis
multiplex. Multiplex, sorry. The way the constellation of physical signs was called Hurler's phenotype. Similarly, radiologically, that is what it's called. Now, I'm just coming to the skull. Can you, now he's very nicely giving us a side view. Can you see the shape of the skull? We missed it during the thing. So it's kind of, this is what we call like a keel. So it's not a classical scaphocephaly, but it's a little like this. Can you appreciate that bump? Okay, and this is what, this is in the AP direction. And in the AP direction, it will come like that when there is premature fusion of the lateral side-to-side sutures. So in this case, as you said, there is ridging of the lamboid, right? Okay. So can we continue with the rest of the investigations?
Just a question. Do you think this is primary craniosynostosis or is it secondary craniosynostosis? Aniket. Any of the students? What is the difference? Prabjot says that primary craniosynostosis will have microcephaly which is associated, not necessarily if only a single suture is involved. Remember he has a borderline kind of head circumference anyway. And it is only for his age, he is grossly microcephalic. For his height, which is really, really short, also it is coming to -2. So keep that in mind.
So, and in any case, yeah, classic microcephaly would come up if there is involvement of more multiple sutures. If there's only lambdoid suture which seems to be involved, so it may not be. So, basic difference, what is the basic difference between
Primary, it is basically a skeletal defect which has caused the sutures to close, which is leading to cranial synostosis. Whereas in case of a secondary, in a secondary cause, it is underlying the brain which is being affected, and
Okay.
because of its reduced growth, the sutures.
Very right. We will repeat what Sukriti said. We will repeat it for the audience because she didn't have the mic. She's right. Primary is when it is a skeletal issue. So there is a primary skeletal abnormality. Therefore, the sutures are getting prematurely fused. Secondary is basically reflecting a poor brain growth, which as in something you might see in children with cerebral palsy. So here, this is a primary craniosynostosis. It's not involving multiple bones. It is just involving the lambdoid suture. And remember, the shallow acetabulum, the shallow orbit leading to proptosis in this child is also a part of the same skeletal malformation, and as is the rest of the skeletal deformities that we see in this child. So it is primary. Yeah. Preeti, you want a comment?
No, ma'am has rightly said the difference between primary and secondary, and to our knowledge, it is important to know even MPS can have craniosynostosis. So when we have this child initially, we were not very sure of the diagnosis, and we were probably not very sure whether it is actually MPS, seeing the size and shape of the skull. But later on we reviewed and we found out that even MPS can have craniosynostosis.
Very rightly said. Though in fact classic complication described with MPS is hydrocephalus.
We have a communicating hydrocephalus.
That is more likely to be happening than microcephaly, which seems to be there. Again, which goes on to say there's a wide spectrum of presentation. So we can hardly be rigid about that because this is present, therefore it cannot be this or it has to be this and so on. So this was, before this, I think this is what we were discussing. I think this case has, what is it, how much time do we have? 6:12. Okay, I think we should be finishing very fast. Just a couple of things, Aniket still needs to tell us what other investigation do you want to get done in this child? You've talked about confirming the diagnosis. Is that all that we need to do in this child? What else is needed for management of this child?
Ma'am, for management, we need to have an hearing assessment, an orthopedic evaluation, an ophthalmologic evaluation, neuroimaging to look for hydrocephalus, and ECG and an echocardiography to look for, which is obvious in this case, he has some clinical findings.
Okay, so this is an important message. Very often postgraduate students are very enthusiastic about making a diagnosis. Once the diagnosis is made, they lose interest because the management issues are complex, and very often we feel, okay, oh, this is MPS, what can we do about it? So let's forget about him. So that's not it. It's a chronic disorder. It's not a totally treatable disorder. It's not a curable disorder, but there's a lot that you can do for any chronic disorder, and this is not an exception. So since we have little time and issues are many, I think we will quickly summarize the management issues here. I think so. The key findings that we had in this case were how we proceeded was coarse facial features, extreme short stature, which ruled out all those systemic disorders, and this short stature was a disproportionate short stature with a short trunk. He had a delayed development, but not really grossly retarded. He has a relatively preserved intellect. The motor development seems to be more involved. He has organomegaly. He has a clear cornea. He has no cherry red spot. As of now, he does not seem to have any neurological involvement. Vision, hearing are grossly normal, and skeletal survey shows a dysostosis multiplex. So having said that, what was our differential? First, as I said, of course, if you put together everything, hypothyroidism is not a differential. But just looking at the child and given the facts that we talked about, so common, so easily treatable, and the impact of not treating is so different, I still wanted to keep it here that this kind of facial features, you must rule out hypothyroidism. After that, you have a differential of lysosomal storage diseases with overlapping features. Preeti, can the next slide. So this is a little busy slide, but this is the kind of exercise you need to end up doing. You don't need to remember it. This is the exercise we have done opening up disorders. Remember, these are all rare disorders and nobody is expected to remember everything. Why should we? You have books to refer to, and please use your books to refer to. So what we have done is we have written our common diagnosis on one side and we have listed the key features of this child. So coarse facial features, short stature, organomegaly, corneal clouding, delayed development, intellectual impairment,
neurological involvement, cherry red spot, cardiac involvement. And we've looked how common these are in all the disorders that we are considering. So this kind of an exercise helps you narrow down because every test costs money. So of course you can do urine test for oligosaccharides also, but you need to be reasonably sure where you're doing. Everything costs money, everything costs time. Good idea to do this exercise, narrow down your differential, and on our basis, if you look at MPS, he has coarse facial features, he has short stature, he has organomegaly. We've written here plus minus because some, say for example type 4, MPS does not have organomegaly. Rest all of them do have organomegaly. Corneal clouding again, some have, some do not have. Delayed development again, variable. This child has delayed development. He does not have too much of intellectual impairment. And he has a cardiac involvement as well. And he does not have a cherry red spot. So with this kind of a conglomeration of finding, especially because his neurological involvement is not much, a whole lot of GM1 gangliosidosis, GM2 gangliosidosis, etc. If you see, neurological involvement is present in almost all of them. And this child has a relatively well-preserved intellect. So this actually was a key fact. This plus the fact that there was no cherry red spot, no blindness, no hearing loss, made us think in terms of MPS before anything else, right? So then we looked at the various MPSs. Where does he fit in? So these are the various MPSs and these are the features. And if you look, he seems to fit in very nicely, as you said, type 1 and type 2. And absence of corneal clouding makes type 2 more likely than type 1. So this is how you narrow your differential diagnosis. So what we have tried to show you is how we reach a diagnosis and how you're supposed to be, reaching out to a child who has dysmorphic features. So this is where we now, at the end of this exercise, we were reasonably sure we are dealing with MPS and most likely type 1 or type 2. Of course, having said that, type 6 and type 7 have identical features, but tend to be much less common. Next, so this is what we have done for this child. We have already done a screening which is positive. We are still awaiting the enzyme activity report. This is available and this is being done for us at Maulana Azad Medical College Genetics Lab, and we are awaiting that report. Management issues, and these are the supportive investigations. We have already got a plain radiograph done. I don't think, I'm not convinced that we need to do a CT cranium at this set. He has no signs of neurological involvement. There is no papilledema. I'm not convinced that we require a CT. Sharmila, any comment?
Actually, there are certain recommendations for both MPS 1 and MPS 2 about when you're supposed to assess at the baseline and how frequently you're supposed to do it, annually or after 2 years, for the various complications which may arise. So at the baseline, yes ma'am, CT should be done.
Alright, great. So having said that, I retract what I said. So we should probably go ahead with the baseline CTs so as we can follow up later. He needs a cardiac evaluation, and that would be important because if MR right now, apart from causing cardiomegaly, is not causing too much of symptoms in the child, but we need to follow him up. And if he goes on to develop complications like CHF or pulmonary artery hypertension, he may become a candidate for mitral valve replacement over time. So certainly needs a follow-up with the cardiology. Baseline ophthalmological evaluation has been done, but again he needs to be followed up. These children can end up developing not only papilledema, they can develop retinal degeneration. So again need to be followed up. Glaucoma is another problem that can come up in these children. Audiological assessment, again repeatedly, they are very prone to ear infections, so hearing loss can develop later, and dental evaluation. Yeah, that's it. And other tests as warranted. I think we don't have time to discuss with management, but these are the key management issues: cardiac evaluation, hearing, follow-up, monitoring for growth, cardiac and respiratory complications, the neurological complications, hydrocephalus, spinal cord compression, ophthalmological evaluation and hearing. And we have treatment available, we have enzyme replacement available, expensive, but it is available for type 1, type 2, both, and bone marrow transplant is of course a definitive cure. And finally, what is really important is parental counseling. Irrespective of whether we are able to offer them enzyme replacement and BMT or not, we need to counsel the parents. And the key issues are regarding this child, what is the prognosis, what is the follow-up plan, what we intend to do for this child, what can and cannot be done, and finally genetic counseling for future children. Anything you want to add, Dr. Mila and Preeti?
Just to reiterate what ma'am said, that a child like this, even if it's not purely curative, there is something which is known as palliative care. And any child with this kind of a disorder requires palliative care. So you just can't shirk your responsibility. You need to plan it out. The parents need to know There are certain schedules. They need to know when to come, what are the danger signs, so that the complications which may ensue, the pulmonary complications, the respiratory cardiovascular complications, the neurological complications are picked up early, and when possible can be treated accordingly.
I think ma'am has rightly said, and it's very important that we keep the child under our follow-up and look how he behaves. And we also want to get a definitive test since the urinary gags have come out to be positive, and let's see what he comes out.
Any comments from the students? Any question? Do we have any questions from the audience, Aniket? Okay, we have unusually quiet audience. I do hope we have some audience apart from our own students. For the people who are not here and who are listening to us, I have given email addresses of all three of us. If you have any comments, any questions related to this case, feel free to write to us. So these are here. With that, I thank my colleagues, Dr. Sharmila and Dr. Preeti, Aniket, for presenting this case well and working up this child and very, very patiently nurturing the child, I would say. And thanks to all the students here. Thank you. And of course, not to miss our little prince and his parents who've been very, very cooperative through this ordeal. Thank you.